You're gonna have fun with it.
Hello, everybody. Welcome to Thursday VMR. Forgive me for my voice. I think I'm catching a little something, but I'm very excited to be here with you today. I've committed to starting these Thursday sessions by um, trying to make it harder and harder and harder for those of you who are joining us not live but on YouTube to not make the leap and join us live. Um, this community is really built on most people who actually started by watching on YouTube, who slowly but surely made the inconvenient decision, I think, in terms of their time to join us live. But I highly recommend doing so for many reasons, in large part because the people who keep this community going and the heartbeat of this community are the people who are here today, joining live and presenting. And if it weren't for the 30 people who are here so far, YouTube would be impossible. We really want you all to hang out with us, get to know you. And I think the best way to do so is by joining us, and even better, by presenting a case. We have seen everything from rare and esoteric diseases to common stuff, and really want to see everything and want this to replicate real life. And so I highly encourage you all to just check out one simple website. It's the one I'll be sharing with you right now. It's clinicalproblemsolving.com/learn-live. Um, that's tells you all about how to join and how to be an active member in this community. All are welcome. Literally, all you need, unfortunately, is internet access. Everything else is details. The details for today are that we are strongly supported by two of our team members who are in the scribing and the teaching roles, and I'll hand the mic to Bayan, who is scribing today, for you to say a hello and tell people a little bit about yourself, Bayan.
Hello, everyone. I'm Bayan Rabih. I'm a final year medical student in Saudi Arabia. Outside of medicine, I really love to read books. Close to hitting 1,000 books now. And they say if you've read 1,000 books, you have a library. So I guess I'll be graduating as a doctor and librarian.
I love that, Bayan. That's so cool. 1,000 is unreal. Congratulations. That's huge. Um, Elena, you want to say hi?
Sure. I'm Elena. I'm also part of the academy. And yeah, I'm so excited for today's discussion because I'm lucky to call Julia my friend. And yeah, I'm just super excited. Julia's not only like good in medicine, but has like so many hobbies and is just such a kind human being. Very excited.
Yeah, I find it very fitting that you're the last person to speak before I introduce Julia, because I remember us gossiping, quote unquote, about Julia beforehand. And yes, it's true. I remember seeing Julia hanging out on VMR quite a bit and hearing directly from somebody who knows her very well, Elena, just about how smart and talented you are and how motivated you are. And I think it's been a treat to see that come to fruition in within the CP Solvers realm. The week before was a Julia week on VMR, but I think it's been months of seeing just how incredibly kind you are, how smart you are, how driven you are, how motivated you are, and we're very lucky that you're pouring that potential and mixing it in with the rest of the CP Solvers crew. And I'm excited to celebrate that today with your first ever case discussion. So I'll hand the mic to you, Julia, to say hello, tell us how you're feeling, and we'll hopefully get you more and more comfortable as the hour goes by.
Thank you so much for these kind words. I really don't know what to say. I cannot emphasize enough how grateful I am to be part of the Academy now. And I've learned so much. And first and foremost, I'm just grateful for all the lovely people I met. Yeah, it really changed my life. It's not exaggerated. So thank you so much, guys. And I am excited. My heart rate is kind of quite up, but yeah, I think I'm ready to go.
I understand your excitement is in large part the novelty of this experience and the fun that we all have. But I will tell you that you have extra reason to be excited because we have a very special case presenter today. I don't think any of you necessarily know Andrew in rich detail, but I've gotten to know him tremendously over the last few months, and have been touched by how much he cares about clinical reasoning and cares about medicine, I learned from him has been consuming CP Solvers content for a very, very, very long time. It's kind of inspiring, quite honestly. So, Andrew, I'm very, very excited that we get to share the stage today, but maybe you can tell folks a little bit about yourself before we jump in.
Yeah, I'm Andrew Gabriel. I have been watching for a long time, and I love it, and I'll continue to do so. Really happy to be on the other side and present you guys a case. Just a little bit about me. I was actually born in Egypt, and most of my life, though, has been here in America, and most of my life has also been in Fresno, and that's where I currently practice. I do both outpatient and inpatient medicine currently, and I enjoy probably a little bit more outpatient currently. And for hobbies, I really enjoy playing basketball, um, solving cases, playing chess, and doing some math. Actually, Robbie, with some time, we got to do some math together.
Wait, seriously? Wow. What kind
Yeah.
of math do you do?
I used to do competition math back in high school, and
Wow.
that never escapes you. But
Yeah.
it's more of just casual math every now and then when my friends get together. It sounds pretty geeky, but
Yeah. Oh my gosh. It's like elite level geeky, but hey, I'm right there with you. Julia, we have a math person, a chess person, and a case solver. So I think my anxiety just went up. Oh, Andrew, we're honored that you're here. Super, super excited. Thank you for taking the time out of your two full-time jobs, both as a doc and as a parent, to hang out with us today. And we're excited to learn from your case.
all right.
All right, Brian, we're ready whenever you are to share the screen. I see, Brian, you've joined from another account, so let me make that one a co-host as well, so you can go ahead and share.
Thank you so much.
Yeah, for sure. No problem. Yeah, I'm gonna go ahead and share. I think that might be a safer thing because I think, yeah, go for it.
All right. So I'm going to start with the chief complaint, which is hip pain. And the first aliquot, by the way, there's a total of 5 aliquots. The fifth one will reveal the diagnosis. The first aliquot is a 58-year-old woman with no past medical history who is presenting to clinic with 1 month of left hip pain. And I'll just kind of give it to you as it's being presented. As you walk in the room, she's visibly in mild distress due to the pain, and her vital signs are 99/62, heart rate of 94, an SpO2 of 97, a respiratory rate of 16, and a temperature of 97. And I'll copy this into the chat.
Oh, what an interesting start. We're walking into clinic, Julia. Very rarely do we get to do so. What are your, I'm curious, what are your initial thoughts as you hear this?
Well, first of all, I'd love to like I found interesting that we have the vitals in the first place as well. So first, having an impression there's localized hip pain, but do we have generalized symptoms as well? So just help me out. 97 is still a febrile, right? Because we're all counting in Celsius.
Yeah.
So there's no. So vitals are stable. Heart rate is a little bit up. The blood pressure is also more in the lower end, but nothing that excites me a lot, like a little bit the elevation of the heart rate. Temperature is normal, so no like very severe constitutional symptoms. And then that is just the first thing I'm thinking about, like local and systemic symptoms. And secondly, I'd love or I emphasize on the localization of the pain. So if it's like unilateral or bilateral, and also if I can notice any like local redness or swelling or anything associated to it, because I would make a difference in like the woman having pain and not being able to walk, or just like having a little bit of pain. And then I would think about like the different buckets I can put it in. Is it like more a musculoskeletal issue? Is it more like localized in the bone? Are there any hints to inflammatory courses? Of course, any trauma I can see that I think would be the first things, but yeah, I'm thinking about.
Yeah, your clinical reasoning brain is a very refined one because immediately you're solving it in a very mature way, which is to try to understand the focal imprints of this disease on the hip, but also if there is a systemic signature. And I agree with you that the interpretation of those vital signs, which at least in the way it's practiced in the United States, are actually often the first thing we get. So a patient checks in, they get seen by a healthcare professional, and the vital signs are obtained immediately. So this is data that often is present well before even the HPI is collected by the treating provider. And so I think that the honest interpretation of these vital signs is that they're equivocal, because a heart rate of 94 and a blood pressure of 99/62 could represent baseline physiology for this person, but it could represent impending cardiovascular collapse. And I think that if we tweaked the chief complaint and said 1 hour of severe chest pain, you would probably interpret those vital signs in a different light. And I think the reason that it's uninterpretable right now or equivocal is because the syndrome is subacute in nature, and the localization is not necessarily in keeping with the syndrome compatible immediately with cardiovascular collapse. So you're open to the possibility that although the blood pressure is less than 100 and the heart rate is greater than 90, that their interpretation may be noise. And I think that's very wise and very mature. And at the end of the day, I think when somebody comes in with 1 month of hip pain, you really, as you did, have to be very careful about not coming to the conclusion that the problem is in the hip, and to recognize that there are many, many issues that can localize to the patient thinking that there's a problem in the hip, including bony issues in that area, and also things that refer to that area. So I agree with you that we'll have to make a lot of progress listening to the patient and seeing what clues that she can provide to help us understand where the nature of this disease is. And so right now, I would be open to a pelvic disease radiating to the hip, a retroperitoneal disease radiating to the hip, or even an upper thigh disease radiating to the hip, in addition to diseases of the pelvis itself. And so, as you said, we'll have to listen to the key clues that the patient provides about whether there's accompanying nausea or abdominal pain, or whether there's pain with weight bearing to help us localize the lesion. And I, like you, I'm trying to understand the lesion itself and trying to understand what systemic features there are. And so I'd be very, very curious what Andrew has in store for us for the next aliquot. Keep our local and systemic buckets wide open. Intriguing start, Andrew. What do you have next for us?
Yeah, excellent questions, guys. So the next aliquot, she's noting that her pain is not lateral, but more medial. And there's no specific incident or trauma that she can remember, but she does note that it's been progressively getting worse. It is worse when walking, but is always present. She's noticing also she's starting to limp because of the pain. She also notes numbness and tingling / shooting pain every time you touch her hip, and it radiates down to her knees. She also notes that she's been feeling weak in that leg. She doesn't have any fever, chills, or weight loss. She doesn't have any chest pain or trouble breathing. No belly pain. No, she does note back pain, but that's been intermittent for the last year, but notes it has been worse over the last month. The past medical history are none. The medications, she's tried ibuprofen, but that hasn't given her any relief, and otherwise she doesn't take any medications. Surgeries, she's had a left knee surgery for a meniscal tear back in her 40s, and a hysterectomy and oophorectomies at age 49 due to uterine fibroids. She has no allergies. She has a family history of an intracranial hemorrhage in her dad, who passed away at age 70, and a son with a history of Burkitt's lymphoma. Her social history, she doesn't smoke, doesn't use alcohol, doesn't use any illicit drugs. She was born in Egypt and moved to the United States at age 30. and she has no recent travel and lives in Tulare, um, also labeled as kind of Central California, and she works as a nurse. And that's the end of Aliquot 2.
I just want to shout out Andrew for like the incredibly high quality presentation here. You're saying a special attention to the scribe and keeping up with the scribe, which I would commend by. And I know it's you don't have many ends of scribing under your belt, Brian, but you're absolutely doing a superb job. Thank you. So Julia, I think one skill that you have that I think would be very helpful for people to hear, especially people who are relatively new to the realm of clinical reasoning, is not analyzing the data initially, but I'm curious what your mental model is of the patient. So what would be your summary of what you think is relevant so far? How would you summarize the data right now?
Thanks for this opportunity. I think it's always very helpful to kind of
Yeah.
summarize for yourself, to like emphasizing on the like issues to attack. So I feel it is like a middle-aged woman. It is a subacute process that's going on for 1 month. And now she's presenting with pain and also some vital abnormalities, so tachycardia and hypotension, which are both mildly. And what's striking to me now is that she presents with neurological symptoms. So she is emphasizing that there's numbness and tingling up to her right knee. And that is the most striking information that were added in the last aliquot to me. I think I would leave it at that,
Yeah.
to be honest.
Agreed.
Yeah.
Agreed. Yeah, I appreciate you emphasizing the neurological dimensions of the case. What would you say they do for you?
I think I would now local or focus not only on the hip but also on the spinal cord. So if there are any like signs of like compression, but I would also think about any vascular causes, not only because of the vitals but also maybe because of the localization, because I felt like medial might be more in the joint. I mean, I was very curious if the woman takes any medication, like if I can think about vascular necrosis or anything that leading to the course, and also you need vessels for like nerve nourishment. But I think I would think a little bit broader and not only like about a local inflammatory or traumatic process here.
I agree with you. It's relatively unusual for patients for garden variety musculoskeletal hip issues to have prominent neurotropic features. And so I appreciate that caution. I'm curious for you how that caution is counterbalanced by the fact that she also has pain that is worsened with walking. And so how are you using that information and how does it compare with the neurotropic features?
I guess, I mean, it could, in my head, it could be both. It could be a local process that is exaggerated or aggravated by pressure. The pressure leading to like more pain because there's like inflammation going on. It could be that also with like standing up, putting weight on the like spinal cord, the nerve compression is aggravated as well. So I cannot really, in my mind, it doesn't lead me to like more nerve compression centrally or more localized issue, to be honest, because both I would expect to be worsened.
Yeah, I completely agree with you. I think when we're thinking neurology, we often think neurology in isolation. And it's often very difficult to trigger neurological disease or manifestations by physical maneuvers. But if you are able to trigger a neurological manifestation by a physical maneuver, it suggests that the neurological manifestations are compressive in nature. And so, you can't make a stroke come or go by pressing on something, but as you just said, you can make your carpal tunnel worse by hyperextending your wrist. And so here I would say that the fact that there seems to be a mechanical component along with the neuropathic component would have you wonder if there's a structural space occupying lesion or process that is both causing pressure, worsening by pressure on the ground as it squeezes that compressive process, but also that compressive process is occurring and compressing on nerves. And so now I think if we have that as a leading hypothesis, knowing that, of course, the history is not robust, what possibilities do you think exist for where the compression might occur? So you mentioned the back, which is by far and away the most common. Any other sites of neurological compression that you would be open to in a patient with unilateral neuropathic symptoms apart from the back?
If it's unilateral, it could be anywhere from like the spinal cord to the
Yes.
actual like hip itself, I
Excellent.
would say.
Excellent. A very rich area of dense localization on the ipsilateral side is the lumbosacral plexus. So it's very, very hard to compress a bunch of diffuse nerves. You need a massive lesion. So when you're looking for a compression for a nerve that's causing widespread symptoms, you're often looking for places where the nerves bundle up together and coalesce together to cause widespread devastation from a strategically small lesion. And so in cases where there is discomfort, when you have unilateral neuropathic disease with discomfort, the discomfort locally makes it almost impossible that the unilateral disease is in the brain. The most morbid possibility. If somebody has left leg weakness, you always have to think about the contralateral brain. But when they have localized discomfort, you're often restricted to either the ipsilateral plexus or the ipsilateral spinal canal. So I agree with you. I think that my history is very concerning for what you said to be a combo of osteoarticular and, or better said, a combo of mechanical spine, lumbosacral spine, or the lumbosacral plexus, which I think makes the medical history now the context of who is this patient becomes interesting. So how now with that hypothesis that we might see something, the radiologist might see something with their eyes in the back or the plexus, how does that help you interpret the medical history?
Sorry, I lost the connection a little bit, so I couldn't really hear what you say. Very sorry.
Oh, no problem at all.
What's the question?
I think we made a lot of progress on the HPI, right? We're saying, sounds very compressive, maybe neuropathic, maybe we'll see something. And now with that progress on the history, how does the context of this patient, the medical history, the surgical history, how does that help you at all?
I think, I mean, she's got a past medical or history of hysterectomy and knee surgery. So there has been some surgery in the past. So I'm wondering, like, what were the causes for the two conditions, and I mean, with surgery, I'll often think about like also thromboembolic complications. I don't know if that can help us here. But besides, there's not, I think it's a tough question because nothing really strikes me a lot. So there's no smoking, no like critical behavior in the past. So I wouldn't be sure. I would probably dive a little bit more in the past medical history.
Yeah, I agree with you. I don't think there's a very powerful thread to pull on in the medical history, and I think that we might revisit that as the case coalesces. So right now, I would be trying to understand not the past, but the present, and trying to see where is the problem currently and how can we make better progress on that. And I suspect the exam might be very telling. Is she weak? Does she have sensory loss? Does she have pain with ranging her hip? All those will be very, very illuminating. And only after we make progress on what we have in front of us will maybe the past be of relevance. Sorry to make you struggle there, but I think vocalizing that
That's all
there
good.
isn't much to pull on is important. All right, Andrew, what do you have next? We're very, very intrigued. Oh my gosh.
You guys are doing great, Julia. It's good to hear you reason through this. So Aliquot 3, I'll give you an exam. The patient is in mild distress due to the pain. They do have an antalgic gait as well, so they're limping when they walk. They do have pain with both active and passive range of motion of the left hip. And there's also exquisite pain with passive abduction and extension. And otherwise, she has regular rate and rhythm, no murmurs, a non-tender abdomen. She has mild tenderness to palpation over the thoracic spine. Otherwise, that's also non-tender. She has normal oral mucosa, no skin rashes. And just to add a little bit to the hip exam as well, because she was in so much pain, it was hard to do other maneuvers, but she did have pain with active range of motion, more so when she did adduction with a D and flexion. I'll also give you some labs as well. The chem panel was normal, chemistry panel. The ALT was 20, the AST was 20, the alk-phos was 70, the albumin was 4.5. The CBC was normal with a WBC of 9.4 and neutrophil percent 75, 1% eosinophils, and 12% lymphocytes. The MCV was 81, the hemoglobin was 12.4, which was normal, and the platelet was 345. The primary care doctor also got a rheumatoid factor, which was 22 and mildly positive, a CCP that was negative, and an ANA that was negative, and she was referred to the orthopedics department, and an x-ray was done at the orthopedic clinic. And I am joining on browser, so I'm not sure if I'll be able to share the first image. Yeah, I'm sorry about that. Maybe I can paste it in.
Hi, buddy. Yeah, no worries at all. Yeah, I think we have plenty of information to work with here. So, Julia, what happened to your initial thought process? Where did your mind go?
So to summarize the exam, what strikes out to me are two things. First, that there seems to be excruciating pain with abduction and extension, but pretty much all other range of motions are also painful. But there seems to be an emphasis on abduction. What I was thinking there is that I think where my mind goes is a little bit that you increase the pressure of the capsular if you do an abduction. So usually like there's more pressure on the joint. But I cannot conclude much more out of these like orthopedic exams. I think there's a lot to learn for me, but also the tenderness on the thoracic spine that strikes out. So I'm still like thinking like, are there any musculoskeletal local issue on the spine that might lead to the nerval compression? And the other thing, like the labs are pretty much normal except of the rheumatoid factor, which is mildly positive, but it's very unspecific. So when we think about like rheumatoid arthritis, we would more concentrate on the CCP. But it does lead us a little bit into whether there can be any like autoimmune underlying disease going on. Yeah, thinking about like SLE also, but or any other courses. But as again, nothing that's like jumping out and being very conclusive in my head.
Yeah, I love that analysis. I will just make note of the fact that your mind really zeroed in on the exam for the hip and made a lot of progress to say that you think that the capsule is being stretched, which is a tremendous amount of progress from the very broad differential diagnosis we were entertaining of all the way in the back and the hip. And you also have not commented at all appropriately on the systemic dimensions of this disease, which seems to have faded. Because as you learn, the patient was able to get up, go get laboratory tests, go to orthopedic clinic with a heart rate of 94 and blood pressure of 99/62. So I think that even though you feel like you might not have made a lot of progress, I would say your vocalization is that you have tremendous, and that you have reduced and really localized the disease, is saying it's not very systemic and it's almost certainly involving the hip joint itself. I too, like you, Julia, I don't have the exposure and the training to make a tremendous amount of progress about what kind of maneuver maximizes the pain. And that goes to show you where I practice. Practice more in acute care settings where the subtle nuances of where it hurts more is less important than thinking about, is this a fracture or cancer? And where outpatient physicians and orthopedic doctors and sports medicine doctors can tell you exactly what's done with the kind of maneuver. I am right there with you. I will not be able to offer that expertise. But I think what we can say is we started off by saying that hip pain is very broad, but hip pain that is worse with manipulating the hip joint localizes the disease to the musculoskeletal apparatus involved. And so I guess if we were to take that localization a little bit further, it would be, I think, that this patient either has a bony disease in the bones of the pelvis or a joint disease in the actual articulation of the hip joint. So I think that's the progress we can make in this circumstance. And I'm curious, Julia, what you think what you think the healthiest or the most productive process to get to the bottom of this? What do you think you would find illuminating as next steps?
So I think, because I'm not appreciating it in the exam, but I just want to make sure, I think in the first place, if there are any other joints involved, so I can really localize on the hip. And if so, what we're trying to do is, is there like two separate processes here? So any nerval compression and also like inflammation, or any like growing process in the joint itself, or if it's like connected. So I think we would probably both need imaging to evaluate whether there is nerval compression and where, and also what's probably interesting to see, even a sonography of the joint would be interesting. Is there like any signs of inflammation or any process going on in the joint? I think these are two things that would interest me the most.
Superb. I completely agree with you. I think that there's no disease that seems to be present anywhere else. And I think that this goes to show you how difficult it is to assess the hip and the shoulder, because if this were any other joint, the knee, the ankle, the wrist, the elbow, you would be able to look and make progress as to whether this is a bony problem or a joint problem. But right now, you cannot tell between a large hip effusion, a large bony tumor, or really anything else. And so imaging is the name of the game for assessing and understanding the progress. And so before we get that imaging, I think it's helpful to outline, as you just said, what the imaging options are. So what do you think the main value add of an X-ray is? What does that tell you in this case?
So X-ray would be very helpful, of course, to assess the bony structures. So if there is like any destructive local process I can see, or degenerative process, or even like a very chronic one. I think that, so for the first impression, that is nice.
I completely agree with you. I think X-ray is really all bones, bones, bones. Ultrasound, as you said, is soft tissue and effusion. CT is bones, 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 and MRI is bones and a soft tissue. So I think we really have to, I think the active question right now in my mind is this a joint issue? or a bone issue. And I think imaging will be really, really important to clarify that. I think we have to make sure that we don't lose track of the neurological dimension that you mentioned earlier and try to explain that at the end. But I think starting off with an X-ray, but recognizing the limitations of the X-ray. If the X-ray is positive, we'll probably follow that lead. If it's negative, we might have to think about X-ray negative bony issues, or that the issue may not be bony, it may be in the joint or in the soft tissues. So, Andrew, I see that your video's off, so you may not be able to share with us, but I'll hand the mic to you to just in case, and if not, we can go to Himun. Oh, there you are.
Yeah, great discussion. So they did get an X-ray, and because it was done at the orthopedic clinic, the orthopedist is the one who interpreted it. And the interpretation was that she had significant osteoarthritis of the hip joint, and she was offered a hip replacement, but she declined. So the next aliquot is that she called her primary care doctor maybe a week or two later, and she said, like, I'm having to hold on to the wall. This is really quite painful for me. I can't walk. And so he ordered an MRI for her, and the MRI had a lot of abnormal findings. The first is that she had extensive abnormal bone marrow signal in the intertrochanteric region of the femur. There was a lot of T2 high intensity over the lesser trochanter, causing a fracture of the lesser trochanter. They mentioned a lot of cortical thinning and permeative appearance of the bone. There was pelvic muscle atrophy. They mentioned expansile soft tissue mass that measured 4 by 4 by 1 centimeter. There was a bone lesion on the ilium that was 1.4 centimeters. And there were several enlarged lymph nodes in the left pelvic wall, the largest measuring up to 3.6 centimeters. And the interpretation by the radiologist said these findings are most consistent with metastasis. A secondary metastatic lesion in the iliac bone, so that iliac lesion that I mentioned was a second metastatic lesion, and patient is at risk for avulsion fracture of the lesser trochanter. So it was partially fractured and it was at risk for totally coming off. I'll give you some more labs as well. So the CEA was 0.8, which was normal. The lambda was 212, and the kappa was 14.4, with a ratio of 0.07, lambda to kappa. The CA 15.3 was normal. A CA 27.29 was normal. And LDH was high at 248. A calcium was high at 10.7. A SED rate of 39. A CK that was low at 27. A ferritin of 330 that was mildly high. An iron saturation of 89%. A TIBC of 256. And then a globulin level of 3.5, which I believe is normal. Oh, they also did an MRI of the spine as well because of the back pain she mentioned, and that was normal. And that's the end of aliquot 4.
Wow, Andrew, what an incredible twist. I think Andrew mentioned earlier that he has 5 aliquots, so the next aliquot will reveal the diagnosis. So I think that's actually a great time to give Julia a few minutes to sit and think about your thoughts, and a great time for us to go to breakout rooms since we have the time. So I've just opened breakout rooms for you all. Feel free to just go in, share your thoughts, or reflect together, and then we'll reconvene as a large group in about 3 minutes or so. All right, see you soon. All right, welcome back, everybody. Julia, you had some time to think and think with some wise people. So what happened there? What happened in that last aliquot?
So much. I mean, we tried to summarize what we find, and I think what's it comes down to is really like having bony lesions, some soft tissue involvement, and also this kappa lambda ratio, which is increased. So both itself make kind of sense, and there are many explanations, but building a Venn diagram to connect these two, we were kind of struggling, because I mean the lesions could be any like hint towards a primary bone tumor or even like osteosarcoma. But on the other hand, we were thinking, how do we connect this to the kappa lambda ratio? Can the patient have light chain amyloidosis or even multiple myeloma? But she's like kind of young for multiple myeloma, I'd say. But I remember that if we like to try to think about the CRAB criteria, that Prof. Raz reminded us once that often we should think about BARC, so the bony lesions being the first symptoms presenting before the others come at play. So I think that's definitely something we can evaluate further in, but I think yeah, it was not. We had a hard time putting the things together.
I don't know. That seems like pretty tremendous progress to me, Julia. That was awesome. Yeah, I'll just emphasize that the biggest thing is to know how to use this case to help you launch the journey that was launched by the primary care team of this patient, which is to know that the X-ray findings of osteoarthritis are neither sensitive nor specific for the condition. The condition of osteoarthritis is basically a chronic degenerative disease of the joint, and so the chronic aspect is required. And the diagnosis of osteoarthritis requires the exclusion of alternative causes. And the exclusion of alternative causes is relatively effortless when somebody has chronic, long-standing, static, slowly progressive disease of one joint. And in this patient, the tempo and the age are really strong arguments against that diagnosis, and I think really, really push you to reconsider. So what could you have seen? You could have seen, in more likely than this explanation, is what's called avascular necrosis or osteonecrosis of the hip, which is one of the most important mimickers of osteoarthritis. But here, I think, unfortunately, you see something much more aggressive. And you see that the patient has a space-occupying process. And finally, I think the explanation on the HPI and the careful attention that you paid on the HPI is bearing fruit, because now you can see and understand totally why this person has pain with weight bearing, the bony dimensions, and has a neurological dimension to it, which is the soft tissue mass compressing probably on the nerves there. And so I think that it goes to show you, which is what people say, the answers in the history all the time. It's not that the history can tell you the patient has multiple myeloma with plasmacytoma with this mutation. No, but it tells you exactly how to proceed and to proceed with caution. And I think now it's all about the analysis of this case. And so, yeah, I think what you did and what you said outright to reflect on the second thing is really an excellent approach to bone lesions. I would say the most productive approach to bone lesions, Julia, is to really understand the systemic fingerprint of the disease. And most of the time when a patient has bone lesions, they often have a systemic disease that metastasizes to the bone. And that systemic disease need not be malignant. It can be infectious. And so this would invoke the idea potentially that this patient has osteomyelitis, of course, not of staph or strep, but brucella, TB, cocci, very possible. If, however, you make progress and you are confident that this patient actually just has an isolated disease of the bone itself, and there is no other systemic disease, the differential diagnosis becomes very narrow. And it emphasizes something that you said, which is to think about multiple myeloma and other paraproteinemic diseases. In not this patient, but the other big one is prostate cancer. And that therein comes the P's for isolated bone lesions. The PSA, not relevant here. Paraprotein, which is very relevant and you emphasized. A PTH, to make sure that this isn't a brown tumor from hypercalcemia. and it's not really it's a fake P, but an alk phos, which helps you analyze, wait, why is the patient having an isolated bony lesion with a normal alk phos? And then finally, the most important infectious mimicker is actually syphilis with the RPR, which usually causes bone lesions on the skull base. So I think the conversation for you and I to have is, are we calling this an isolated bony disease? Or is this a bony disease with extra bony fingerprints? And so what you make of the soft tissue mass, the enlarged lymph nodes, how does that shape your calculus? What do you think?
I would definitely think that there are many fingerprints towards a systemic disease and not only a localized one. Yeah.
And what would you say those fingerprints are? Like, what is catching your attention as to things to worry about?
I think first the elevated LDH does lead me towards a systemic process. Also, so calcium 10.7 is elevated, right?
Yeah.
Or the 7, yeah. So the hypercalcemia also would lead me to a local to a systemic fingerprint. Ferritin.
Yeah.
Yeah.
Yeah. I love that. I love that. And I think you should hold on to that, because what if I said this, Julia? This is a person with a super, super abnormal serum free light chain ratio who has a lytic bony lesion. How could this, and hypercalcemia, how could this not be on the spectrum of multiple myeloma, right? There's a very strong case for it. Lytic bone lesion, really bad paraprotein, hypercalcemia. Those are arguments in favor of multiple myeloma. What would you say are arguments against multiple myeloma?
Against what? So there's no anemia present at the
Yes.
moment. So the hemoglobin is still within normal range, and also the platelet counts is not the platelets. I mean the white blood cell count is normal as well. So that's very interesting.
Agreed. You know, the curiosity about multiple myeloma is it disproportionately affects the hemoglobin and spares the white blood cell count and the platelets. And the helpful mnemonic is CRAB, but I encourage you all to toss that mnemonic out and use the CRAB in reverse and use BARC, B-A-R-C. Bone lesions, which this patient has, anemia, which this patient doesn't have, renal insufficiency, which this patient doesn't have, and then hypercalcemia. And a big, big argument against multiple myeloma is the sequence of events. Most patients will go through the BARC sequentially, B first, then A, then R, then C. The presence of hypercalcemia in this patient without concomitant anemia or renal insufficiency is a decent argument against multiple myeloma, as is the presence of a soft tissue mass and lymph nodes. Multiple myeloma is such a bony tropic disease, it very rarely forms soft tissue masses or lymphadenopathy, with the exception being the patient having a plasmacytoma. So we're near the end of the hour, Julia, but the only advice I have is it is very tempting to say bone lesion plus positive serum free light chain ratio equals multiple myeloma. This is not a classic presentation of a multiple myeloma. And the counter arguments are the disproportionate hypercalcemia in relation to the anemia and renal insufficiency and the presence of soft tissue masses. So I think we should proceed very cautiously, being open to a sneaky infection where this patient's history and epidemiological exposures in Egypt would bring TB and brucella into the calculus. Her residence in Central California would have us worry significantly about the possibility of disseminated coccidiomycosis, which I would not be surprised she has. But more importantly, a metastatic malignancy of solid origin that has metastasized to this area. So don't get locked into this being a paraproteinemic disease. It could easily be something else. So before we hand the mic to Andrew to take us home, I'm curious, any other thoughts you wanted to share or reflections before we hear from Andrew?
I am amazed by your last 2 minutes, to be honest. That was such an amazing summary of all the findings we have. I think there's not that much to add from my side. There was just one question I wanted to ask a little bit earlier, to be honest. I was thinking, was there any time where you were considering tapping and analyzing synovial fluid of the joint?
Yeah.
If you have, I mean, yeah, the
It's a great,
systemic, yeah.
a really good question. And I think ultimately it goes to show you how with hips and shoulders, you don't know if there's a joint problem until you image the patient because you cannot examine it. And it turns out in this patient, she does not have a joint problem. Her entire complex is bony disease. And so if tapping her joint, you probably would get little to no fluid. And so when you say hip, you should really say hip joint versus bony disease of the pelvis. And you're seeing here that this is a bony disease of the pelvis. And the question remains, is this a bone lesion like multiple myeloma, or is it systemic disease going to the bone, but not the joint? Andrew, even at the hour mark, there's so much tension left in the case. What do you have in store for us next?
I put a lot of red herrings in. Just to clarify,
Yeah.
after they got the MRI, they did refer them to the oncologist to kind of work up for this metastatic process. And that's why all those specific cancer tumor markers are there. I don't want everybody to think that you can just order cancer tumor markers willy-nilly. But they ended up doing a biopsy of the lymph node that they saw in the peritoneum, the abdomen area. And the ultimate diagnosis was a B-cell lymphoma. They were debating between diffuse large B-cell lymphoma, maybe a primary lymphoma of the bone, and also there were some features of Burkitt's lymphoma. But you guys were on it because we were all thinking similar things, like, could this be a metastatic process of malignancy? Could it be an infection? There was, I think one of the doctors we saw said, the patient was really in distress and really was not at ease when she heard the metastatic part. And one of the doctors told her, this could just be lymphoma. And that might be the best case scenario. So it was lymphoma, and she received R-CHOP therapy for it, and she actually made a complete recovery. She did have to go and receive respirocase due to some tumor lysis that she experienced and had a lot of mucositis, but she did recover from it. The free light chains as well can happen. They can be elevated with B-cell lymphomas, and they also decreased during the course of her therapy, but completely normalized 6 months after her therapy. And she is several years out now, cancer-free.
Oh, wow, what an incredible case. Julia, what are your reflections?
Thank you, Andrew, for this case, and also that you took the time on not easy day for you, taking care of a sick child. So that's really amazing. Thank you so much. Well, I learned a lot. I don't know where to start. So first of all, I learned how even if you don't have an exact idea, just like narrowing down on like the specific fingerprints you have helps you a lot in progressing. So that was like a key learning point for me. But especially like I loved how you emphasized that the like the frequency of symptoms and multiple myeloma is very specific. So I love how like the discrepancy between like the hypercalcemia occurring before like any signs of anemia kind of makes the diagnosis of multiple myeloma very unlikely. So that was one of my key learning points, I think. Yeah, thank you so much.
Yeah, Julia, your ability to handle this case was brilliant, because the HPI was, I think, the key aspect of this case, and you're like neuro plus hip. And then you use the exam to be like hip, hip, hip. There's something wrong stretching the hip capsule. And I think that we ultimately learned that the X-ray was a trap, and to proceed despite the X-ray was really, really key. And I think the final segment that Andrew gave us the opportunity to reflect on is a key concept about interpreting a paraprotein. And I will tell you, these schemas are all available on rlrcpsolvers.com, and Reza will be very mad at me that I'm sharing it now, but whatever. He won't be mad at me. He doesn't care. But I would just wanted to introduce the concept that paraproteins in the form of a positive SPEP or free light chains don't necessarily all come from plasma cells. That a large number come from lymphocytes. Most classically splenic marginal zone lymphoma, which has a 50% rate of a paraprotein, to CLL 20%, and any lymphoma can do this. So I think if you were to really try to get as much juice out of the last aliquot, you would say the following. The patient has a paraproteinemic process. However, the paraproteinemic process does not seem to be restricted to bone, forcing us to move beyond the most common source of plasma cell to entertain the possibility of a lymphoid or a lymphoplasmacytic process like a lymphoma. And ultimately, when you look back at that and you see, well, okay, disproportionate hypercalcemia, LDH elevation, the signatures are for lymphoma were there to pick up on. And so my advice for all of you is to take advantage of the paraprotein and not ignore it, but to take advantage of it, not to falsely push you towards multiple myeloma, but to open the world of hematological diseases, which this patient ultimately had. But Andrew, I'm really curious, having shared this journey with us, what learning points you want to emphasize? And I know it might not be a good time, so feel free to pass the baton. Yeah.
No, actually, I do want to share a few points. Thank you
Yeah.
for giving me this opportunity. One thing that somebody mentioned to me in residency, one of my preceptors, Dr. Brickner, we were just going over musculoskeletal complaint, and she just wanted to interrogate me and said, "Do you think this could be cancer?" And I said, "I don't know." And she told me, "Well, cancer usually gets worse over time." And I think that was a key thing to bear in mind. Many joint complaints come and go, and they wax and wane. But if you hear something that's progressively getting worse, it's important to perk up your ears. Also, if you ever see a lesser trochanter fracture, it's automatically a pathologic fracture, so it's good to work that up further. Really important to keep listening to your patient. Okay.
So cute.
And also, passive range of motion, something I learned from Yusuf actually on the clinical problem solvers, is if you hear passive range of motion greater than active range of motion, is think more of in the joint or affecting the joint itself rather than the tendons and muscles around it. This, I didn't get a chance to share the x-rays with you, but actually the fracture was partially visible on the initial x-rays as she went to the orthopedic doctor. It's really important to try to pull up the image yourself and try to match the patient's symptoms and look all the way around the cortex, not just at the hip joint as well. And then if at some point you'll kind of come up with your own screening labs for patients that you don't want to miss diagnoses for, and ideally you want to be cost-effective, have cost-effective care. The ones that I currently do are like a CBC chemistry panel, a calcium level that sometimes gets missed, an LDH, an alk phos, and liver enzymes, and ESR CRP. Some of these are a little non-specific, but the point of this is to have kind of a low-cost lab to kind of be sensitive in catching diseases. And then I also learned numbness and tingling, nerve pain. It kind of correlates with how deep something is being affected. And it was kind of affecting, maybe the lumbosacral plexus with all those lymph nodes and the expansile mass. But I think also the expansile mass itself was also causing nerve pain and the lesser trochanter coming off. I think that's mainly what I wanted to share with you guys. Thank you.
What an incredible hour. I mean, this is one of my favorite. I mean, we've been having incredible cases this week on VMR, but to have an outpatient case proceed in the outpatient manner where you don't know that you're sitting on something very, very serious. And I think the points that you emphasize, Andrew, the nuances on physical exam, the attention to progression, the value of a screening, targeted screening labs to help you augment your suspicion for something systemic was absolutely awesome. What an incredible case. Really, really appreciate you taking the time to be here and know the additional hurdles that you are balancing right now, which are really appreciated. And Julia, I just want to give you a big high five. That was an awesome discussion. Really, really enjoyed sharing the stage with you. And now we get to hear from your friend Elena for the teaching points.
Yeah, thank you, Andrew, so much for this incredible case. And Julia, I want to say that I think the hardest part discussing a case in front of a crowd is to like not get like sucked in by the case. And I think with every point I was seeing you like in front of the patient and like not being like sucked in by like one data point. So great job. Yeah, I'll keep it short because I really love the teaching points of Andrew. We started with arthralgia. We started with an anatomic approach, thinking not only of the bone and the joint itself, but also of the extra-articular space, the skin, soft tissue, but also referred pain, which was important in this case from the pelvis, the retroperitoneum, upper thigh, and lumbar spine. Andrew shared with us that the patient had significant neurotropic features like numbness and tingling, which usually are very unusual for disease inside the joint, but more indicative for compression or structural lesion in the cord, the plexus, but also the peripheral nerves. The patient also had like some claudicatio, which like further supported our hypothesis of some kind of compressive lesion. And some branch point was that the hip pain worsened with movement, which was then suggestive of an MSK disease, namely the bone and the joint. Then we saw this like imaging with the multiple bone lesions and also the soft tissue mass. And Rabih shared with us that when we have bone lesions, they're often secondary to a metastatic infection, malignancy, and also autoimmune processes. And but without systemic features, we should think of a local disease. We usually work up bone lesions with the 5 Ps, so with PSA, paraprotein, PTH, ALK, FOS, RPR, and the lesions of the syphilis are usually in the skull base. We had also in the chat like a lot of cool points about multiple myeloma, which is a very difficult disease. And we learned here in this VMR space many times that instead of using the crab mnemonic that we all probably learned in medical school, we should rather focus on the BARC mnemonic, which is usually how patients present, so with bone lesions, anemia, elevated creatinine, and hypercalcemia. Therefore, if you have hypercalcemia in a patient with suspected multiple myeloma, we would expect anemia as well, because multiple myeloma disproportionately affects erythropoiesis, not so much the white blood cell count and thrombocytes. Yeah, and also the presence of the soft tissue mass that the patient have and lymphadenopathy is not so likely to be multiple myeloma. Yeah, that's all for my part.
Amazing. Wow, what an incredible recap. I feel like you were paying attention to the case, to Julia's like body language as she engages, and also the teaching points over me. That was awesome. Thank you, Andrew. Thank you, Bayan, for scribing. Thank you, Julia, for hanging out for a fun, rich hour, and Elena for the teaching points. I hope you guys have an amazing day. See you next time.